Hi everyone, welcome to episode 7 of a comprehensive review of dermatopathology. Today we're going to be covering infections, which is kind of a huge topic, but I'm going to try to introduce it to you. And then it will actually be the final chapter in our part 1, which is the inflammatory conditions. So what we're going to cover is we're going to cover kind of more common bacterial, fungal, viral, protozoal, and infestation type processes that we see in the skin. So beginning with bacterial infections, you commonly will see impetigo very superficially, a cellulitis. We'll look at different bacteria that we can see, Corynebacteria, Neisseria, mycobacterial infections, Rickettsia, Bartonella, and actinomyces. So impetigo, this is very common. We see staph on the skin all the time. And commonly you'll see a subcorneal pustule, and you'll be able to see the clusters of blue cocci. Often you can see a blistering version of impetigo with superficial acantholysis. So subcorneal pustule, remember in an earlier section we talked about the differential diagnosis for a subcorneal pustule. That includes a pustular jug eruption such as AJAB, pustular psoriasis, dermatophyte, impetigo, Sneddon-Wilkinson, etc. And then it can be confounded by the fact that you might have impetiginization of another one of those processes. But here, in this case, with the clinical information, that was consistent. This was impetigo, and you can see these clusters of blue cocci in this pustule. Okay, other clusters of blue cocci. These are staph. This is a case of bullous impetigo. So bullous impetigo has things with superficial acantholysis on the differential. So a lot of people think about superficial pemphigus or pemphigus foliaceus. One of the ways that I distinguish them is that they tend to retain their round shape in their acantholysis, and it's down in the spinous layer as well in the granular layer, whereas pemphigus foliaceus tends to split only in the flattened granular layer. You don't see these round acantholytic cells in the pustular space. But that's not a hard difference. That's just kind of a clue that helps me distinguish them. But this is a bullous impetigo. All right, so cellulitis, now as the infection with similar bacteria heads deeper in the tissue, you might see neutrophils and edema in the dermis for a cellulitis. It'll be kind of nonspecific. Or, slightly deeper to impetigo, you might see ecthyma, which would be ulcerated and have sort of a cellulitic component below it with the neutrophils. You might see bacteria now in the tissue instead of just resting on top of the tissue, which is easier to view with a gram stain. The bacteria, as we saw, were easy to view on H&E when it was on top. So this is actually a case of ecthyma that came in recently, and this is sort of some granulation tissue, but you can see that you're in the dermis and you have a lot of blood vessels, probably because this is an area affected by stasis, but what you see throughout the tissue is neutrophils. It's kind of a non-specific thing, but you see neutrophils, and then on a gram stain is when you can appreciate the little gram positive. Remember, dark blue means gram positive, red is gram negative, cocci in the tissue itself. Other superficial infections we might see are pitted keratolysis and erythrasma, and these are usually Corynebacterium, and this is going to be a filamentous bacteria at the surface of the cornified layer. Erythrasma looks pretty much identical. So here's acral skin, right? We have thick epidermis, thick orthokeratotic cornified layer, and at the very surface, you can sort of appreciate these filamentous bacteria. This is an axilla for erythrasma. It can be a little bit hard to see, but sometimes if you do even a PAS stain, you can see bacterial organisms, or a gram stain, you see the bacterial organisms, and here you can appreciate these filamentous bacteria in the cornified layer for erythrasma. This is a gram stain showing of the same tissue, showing that they're gram positive. So other Neisseria infections, you might see a septic vasculitis, right? So we saw that in the vasculitis section. But gonococcemia would be an example of this, meningococcemia also. So you're going to see inflammation in the dermis with fibrin thrombi. And then a sign for infection would be neutrophils, right? Other vasculitides like leukocytoclastic vasculitis, I put more in an allergy category. So you're going to see newts and eos. But if you see just a lot of vasculitis with lymphs and neutrophils, then you might think about something infectious. And certainly if you see some cocci in a thrombosed vessel, that would really seal the deal for you. But what you can see here is that with the vasculitis and the acuity of this, you have a lot of edema, but you also have an eschar up here. So what's an eschar? Well, an eschar is fibrin, right? You damage the tissue, you get fibrin to plug it. And you also have serum and inflammatory cells and dead tissue. So all of that mixed together gives you the eschar, and that's from poor perfusion. So why do you have poor perfusion? You're going to look and you have this superficial and deep inflammatory cell infiltrate, and you start to see these little clumps of fibrin suggesting that your vessels might be plugged. And if you look around, you see lymphs, you see histiocytes, you see neutrophils. You don't see a bunch of eosinophils, right? This is not an allergic process. And then you see fibrin in your vessels because they're damaged, and this is a little bit of a thrombotic process as well. And then you might, if you're lucky, see cocci inside of your vessel. Mycobacterial infections we see varying patterns for. So leprosy is something that we see a lot in the skin. Remember, if you see a tuberculoid form of leprosy where it's mostly just granulomas that are non-caseating, you tend to have less organisms. Whereas if you have more of a lepromatous leprosy, where you have less granulomas, more like lymphs and other inflammatory cells, then you might see many organisms. If you have the tuberculoid form, they often will form elongated sausage shapes rather than retaining this kind of round circular shape you might see in sarcoid, which would be on the differential. It will encase nerves, which might be a clue. All right, so let's take a look. So here we have a case where we see these elongated sausage-shaped granulomas, right? This still classifies as a nodular granuloma, but rather than being individual circles, they're kind of conjoining together. So that's one clue you might be dealing with leprosy. And then the presence of lymphocytes here suggests that maybe you're not dealing with a naked granuloma, but as I emphasized earlier in another lecture, sarcoid is not always naked, so you can't hang your hat on that, which is why for any case you're going to rule out infection. Here's another case of leprosy. Again, you have these sort of elongated shapes, but when you go in closer, this one's less granulomatous than that other one. This one's got newts, it's got lymphocytes, and it has histiocytes. So this is probably going to be higher organism count for this case of leprosy. Here, when you look up close, there's a little nerve encased by your inflammation. Your inflammation's been around a while. You're starting to pump out antibodies. So of course you have some plasma cells. And here is a phyte stain. This is not for that case, but this is a phyte stain of what you might see with lepromatous leprosy. Lots of organisms, right? Where sometimes it's hard to find any organisms. Mycobacterium marinum, I present this because we had an outbreak of this in the fish markets, Chinatown fish markets in New York back a few years ago when I was there. And here you're going to see separative and granulomatous inflammation, poorly formed granulomas. All right, so here you can see that you have these cells that are pinker and larger, and these are granulomas with neutrophils inside, so separative granulomatous, and you might have a lot of tissue necrosis in these areas. One of the keys for finding infection is to look where the neutrophils are. That tends to be where the organisms are. And in this case, when we did the phyte stain, you could see the mycobacteria, but often if you do the special stains, the sensitivity only rises to about 18 to 20% in a study we did. Tissue cultures, you might only reach 35%. So if you really suspect infection, sometimes you have to go all the way to PCR and send your tissue to the CDC, which is part of how this outbreak was discovered, was because an astute pathologist at our laboratory kept sending them to the CDC, who alerted the public health department. But sometimes you're lucky and you can get organism in your special stain. All right, bacillary angiomatosis. So this is another lesion we'll see on the skin. These are Bartonella organisms, right, with cat scratch. and you see these vascular nodules or papules. And under the microscope, they're PG-like in the sense that they kind of appear like granulation tissue with increased blood vessels, edema, and mixed inflammation. In this case, you'll have these kind of rounder endothelial cells, and then you'll see collections of the bacteria. So in this section, you can see this vaguely nodular proliferation of increased blood vessels, right? So that's the amount of it that looks somewhat PG-like. And that's why it might look purplish clinically to you, is because of all the increased number of blood vessels. The presence of neutrophils should make you, suspect the possibility of an infection, though of course you'll see neutrophils in a PG also. And then what you're going to see is these little collections of purple granular material, and that is your bacteria. Here's another case, nodular, very vascular. You can see it's very congested vessels here and inflamed. Up close, you see all these little vessels packed with neutrophils, because neutrophils love to fight infection. You go in closer, and here, these are your little collections of this purple kind of granular material. These are your Bartonella organisms, okay? Bacillary angiomatosis. We also see rickettsial infections in the skin. Back in New York, we saw rickettsial pox. When I was in training in the Midwest, we saw Rocky Mountain. I probably won't see as many rickettsial things out here in California, but things to remember is you're often going to have a superficial and deep lymphohistiocytic infiltrate, and you may or may not have a vasculitis with it. So, patterns will repeat themselves in infections. Often there is an LCV, often there is an interface. So it's kind of non-specific, but what we're going to notice in our infections is you're either going to just have neutrophils or neutrophils plus vessels, or suppurative and granulomatous inflammation, or you're going to have this kind of lymphocytic infiltrate, or you're going to have a vasculitis. Those are kind of the different patterns that we'll see. So here's a case that should remind you a little bit of that gonococcemia case where you have an eschar again. So an eschar from poor perfusion, because you have this dense, superficial and deep infiltrate with vasculitis in it. And here you can see the fibrin around the vessels, and it's kind of a blurry picture, but you might have some neutrophils and lymphocytes. I'm sure you probably have some plasma cells too. But these kinds of non-specific little necrotic papules, as you know from being on consults or something, if you see necrotic papules, you do have to think about infection. And you may or may not be able to find organism. A lot of time you'll need to diagnose them serologically. Here's another case where you don't have a large eschar, but you still have this superficial and deep infiltrate with some vasculitis. There's a little bit of an interface here. Sometimes that's a clue. Sometimes you'll see these elongated cells that at one point I thought were activated lymphocytes, but at some point I've decided that they may not be, and I've talked to experts such as Dr. Phil Lebois, who's named them twistiocytes. So from here on out, I'm going to refer to them as twistiocytes, and maybe they're dermal dendritic cells. Nobody knows exactly what their cell of origin is, but we tend to see them in infectious processes. So if you start to see a lot of these elongated cells, you might think of infection, and be that bacterial things, viral things, anything. I'm noticing that a lot with infection. So this one has an interface with the superficial and deep infiltrate and the vasculitis for rickettsial things. A mycetoma, so if you see grains, you can have chronic infections that are either fungal, which are less common around here, or they're bacterial, like actinomycetoma. We see these, kind of in the oral mucosa. And they're beautiful, and they're characterized by this Splendori-Hopley phenomenon, where you get this eosinophilic material that surrounds organisms. And you see all this pink and purple, and actually it's kind of hard to see exactly what the bacteria are without a stain. But here's a bunch of pink and purple, and you can see that it's lined by this eosinophilic material, and that's the Splendori-Hopley phenomenon. Here it goes again. Here's your neutrophils, of course, because it's an infection, your body's fighting it with neutrophils. Here's another up close of a different Splendori-Hopley. And somewhere in here you have these sort of filamentous bacteria. All right, spirochetes. We talk about spirochetes a lot. So we'll see syphilis in the skin, Borrelia, So for Lyme, we'll see erythema chronica migrans. This is actually a case of primary syphilis. So secondary syphilis, we talk about all the plasma cells that we see because, of course, it's a chronic infection, and now your body has been pumping out antibodies for a while, so you're going to have plasma cells. Primary syphilis, you're going to have an ulcer, and then you're just going to have a lot of inflammation. In this case, it's superficial and deep, mostly lymphocytic infiltrate with neutrophils, right? And then up close, here's your neutrophils up in your epidermis, and you might even see some of these elongated twistiocytes and a little bit of an interface in this case. Here's superficial and deep. Here's all your little smooth muscle bundles, because this was, you know, in the male genitalia area. So smooth muscle, and then admixed with lymphs and histiocytes, kind of a non-specific eruption. This is the T. pallidum immunostain. So these are the little spirochetes. So a lot of times you'll have background staining, but the organism itself should really look like a little corkscrew, like a little elongated corkscrew. Hence the name spirochete. So this is what we classically think of when we think of syphilis. We like to see it to be a psoriasiform with elongated skinny reedy, lichenoid, right? We have lymphocytes obscuring the DHA. In this case, you see how elongated they are. So we see twistiocytes in this case. And then an infiltrate with lymphocytes and plasma cells indicating the chronic infection. I also like to see some neutrophils, right? Because it's an infection. So this is a classic case of syphilis, but syphilis can look like anything. So you always have to have it on the back of your mind when you're thinking, why am I seeing plasma cells or something like that? This is condyloma lata. In this case, your epidermis is very, very acanthotic, almost parigo-like, right? Bulbous around the adnexal structures. And then we should see other similar findings of, you know, maybe a little bit of an interface with the elongated cells, a lot of neutrophils because it's an infection, and certainly a lot of plasma cells as well. So other spirochetes. So erythema chronica migrans. This one is classically what we think of as a lymphocytic infiltrate, right? We put the gyrate erythemas in our lymphocytic infiltrate differential. However, I will say that having studied a lot of these cases back in New York, there is quite a range of what we see. We might see a very sparse superficial perivascular dermatitis. We might see dense superficial and deep perivascular and interstitial dermatitis. We might see plasma cells in half the cases. We might see eosinophils in half the cases. But what we did notice that we saw in almost all the cases was a little subtle interface or a little sponge with our twistiocytes that made us think about whether or not we were looking at an infection. And then, of course, with the clinical information, you could then be more or less suspicious of erythema chronica migrans. So here it is, perivascular lymphocytic inflammation, maybe some plasma cells, maybe a little bit of a subtle interface. Maybe you'll see some twistiocytes. Here's an up close in case you wanted to see some lymphs up close, maybe a plasma cell or so. This is what a Warthin-Starry stain looks like. So, you know, in theory, maybe a spirochete immunostain such as T. pallidum might pick up some Borrelia, but I haven't really seen that to be the case. Warthin-Starry is sort of a difficult stain to use because your elastic tissue stains black in the background also. But we do it anyway to check it on the box and tell you that we were suspicious of it so that you'll check serologies, which is a much more sensitive test. Okay, this is not a spirochete. Well, actually, this is in different tissue and it looks really good in this tissue, but this is not actually what the Lyme organism looks like. Okay, so now that was bacteria. Moving on to fungal. We have very superficial infections and then deeper infections. And when we talk about fungus and yeast, what we're talking about really is how does this organism exist in vivo, right? You have things growing in Petri dishes, you have things growing in your tissue. So in your tissue, are you in yeast form, like the little circles, or are you in hyphal form, like the branching, you know, elongated structures? Yeast infections that we see are Candida, Pityrosporum commonly. Fungal infections that we'll see are dermatophytes on top of the skin, Stomatiaceous fungi can be superficial or deeper, and then systemic or deeper fungal infections that we might see more commonly would be blasto, cocci, histo, crypto, etc. Okay, so this is a yeast, Tinea versicolor, and one of the clues for dealing with a superficial yeast is that it's very easy to see on H&E. Like everyone can see this very clearly, right? So if I see it this clearly, then I suspect that I'm looking at a yeast like Tinea versicolor over a dermatophyte. Again, here is Candida, and you can very clearly see these yeast forms. It might be a little bit harder to see the pseudohyphae, but you can still see them in there. This is as opposed to this. This is what a dermatophyte looks like. It looks invisible. You can only see maybe a little hole here, or you can trace little absences in the cornified layer where you might suspect there's a hypha, but it's much more difficult to see. In this case also, this is what we call the sandwich sign, where you have parakeratosis, maybe some neutrophils alternating with orthokeratosis. It's not very specific, but we do see it often. And you might suspect tinea, but anytime you see a sponge and you have a few neutrophils in your cornified layer, you should suspect and want to rule out tinea. Looking up close, we cannot see obvious hypha, right? Although I'm starting to see little spaces where I suspect maybe there are some. And then you do a PAS stain, and there you are, your septated hyphae. So, hard to see dermatophytes. Candida, pseudohyphae, dermatophytes, real septated hyphae. Okay. Blasto. So you can either have disseminated blasto, or you can have primary cutaneous blasto, right? You either inhale it and it goes from your lungs and your bloodstream out to your skin, or it comes in from your skin. The keys for this are pseudoepitheliomatous hyperplasia and suppurative granulomatous inflammation. Anytime you see suppurative and granulomatous inflammation, which equals neutrophils plus histiocytes grouped together, right? You need to think of infection. Certainly with pseudoepitheliomatous hyperplasia plus suppurative and granulomatous inflammation, it's going to be an infection until proven otherwise. Even if your special stain is negative, even if your tissue culture is negative, I would pursue that to the end or treat it empirically. The only other case where you might have suppurative granulomatous inflammation in the skin commonly that we see would be like a ruptured cyst. Okay, so here's blasto. Here's our pseudoepitheliomatous epidermal hyperplasia. What does epithelioma mean? In the past, they used the term epithelioma to refer to a low-grade carcinoma. So this is synonymous with pseudocarcinomatous epithelial hyperplasia. So either term is fine. If you were to transect this biopsy here, you see this glassy pink cytoplasm. I've seen this called surface of squame more times than I care to recall. Okay, but here we see this is not a squame. It's fairly well differentiated. There's not significant atypia, and we have suppurative and granulomatous inflammation. So here's our granuloma, right? Our multinucleated giant cells and our neutrophils. And this is where you're going to start looking. You're going to start looking for little organisms. And here we just see little holes, right? Blasto is small relative to our other yeast. Histo is actually even smaller, but like cocci is much larger. And blasto just simply as a wall, there's nothing inside. A lot of times in your picture books, they'll show you GMS, where you see the little circles or the circles next to the circles, right? Because they have the broad-based budding, which just means they bud off each other and the little circles connect. But this is what it looks like in H&E, just a circle with a hole in it, okay? Here's your GMS, and here's your circle next to your circle, the broad-based budding. So cocci, like I mentioned, is larger organism with endospore. So now you've got a circle with little circles inside. But the same pseudoepitheliomatous or pseudocarcinomatous hyperplasia, and you might have suppurative and granulomatous inflammation. So again, pseudocarcinomatous epithelial hyperplasia, and we see giant cells, and we see neutrophils, and then we see all these much larger circles than we did before. Everyone see these organisms all around? Going in closely, circles with little circles inside, right? Not an empty circle, bigger. That's cocci versus blasto. See, and the rest of these are your histiocytes with neutrophils mixed together. That's your suppurative and granulomatous inflammation. Histo is going to have granulomas also, suppurative granulomas or just granulomatous. They're parasitized histiocytes or macrophages. That just means that you see them inside the histiocyte, but the histiocytes are eating them regardless if they're big or small. It's just when they're small, you can see them sitting inside them much easier. And there's a little halo. So here, look again, pseudoepitheliomatous hyperplasia. You probably have a little bit of suppurative and granulomatous inflammation. But here inside your histiocytes, you see these little tiny organisms. And the main differential, sorry, for this is going to be histo or leishmaniasis. And we'll talk a little bit later about how we're going to distinguish those. Cryptococcus is encapsulated, and it has a refractile mucinous wall, which you can sometimes see or sometimes you can't see. So if you can't see it, there's like a white space where there would be a wall. If you can see it, then you're going to see a bluish wall around it. So here, what you see is a lot of white spaces set in this dense infiltrate. You can see your newts, right? Your multi-lobe little dotty cells. And you can see these purplish histiocytes in the background, but then there's all these little white circles. So when you go in closely, this is the little halo around the nucleus, right? This is the nucleus and this is a halo. And that's what that's what crypto looks like. Sometimes you can see the blue wall, but sometimes you just see this like lack of the wall. Here's another picture of crypto. In this particular case, you can see this mucinous wall, right? You see that bluish wall around there, and it's got this little nucleus inside, whereas blasto is just the circle, okay? No mucinous wall, no circle inside, just an empty circle. Similar in size, however. Dermatiaceous fungi, these are pigmented fungi, pigmented with melanin. So if you do a melanin stain, you can find the fungus as opposed to even doing a PAS stain, which would probably still find it, but you know, it's kind of neat to be able to do a melanin stain. So chromo is when it exists in yeast form in the tissue, right? That's how you get the copper pennies. And then pheo is when it's hyphal form and it's pigmented. So often these are, if it's in the skin, you're going to see a chronic abscess in a cystic form. It'll be like a nodule in the subcutaneous tissue. So here in the cornified layer or the nail, you're going to see little copper pennies, brown, right? Little yeast forms. In this case, it's deeper in the tissue. You've got your pseudoepitheliomatous epidermal hyperplasia and your suppurative, often suppurative and granulomatous inflammation. You've got all your little brown organisms, okay? Little brown organisms, copper pennies. This is called a pheohyphomycotic cyst. It's that cystic chronic abscess I was talking about, deep in the tissue. This particular one's probably been around a while. It's a little fibrotic, but what you have is suppurative and granulomatous inflammation. And in the center of it, where your neutrophils are, you're going to start looking for little pigmented organisms, which here on a Fentana Masson stain, you can see very nicely. Okay? Yeast forms that are pigmented. Okay, and that's it for fungus. Viral infections. So we see a lot of different viruses in the skin. Of course, there's molluscum that we see commonly, right? We read about ORF, although in the places I've lived, I haven't seen ORF that much. Herpes viruses will come across a lot, you know, even Merkel cell, a subset goes in this viral category. Pityriasis rosea, remember, goes in this category. Dress syndrome, even though it's a drug reaction, also is somewhat of a viral process. And then of course our HSV and VZV. Papova viruses, we see a lot of condyloma, EDV, and verruca, and then picoRNA viruses, hand, foot, and mouth. And then of course, you know, our newest entry into the list would be COVID, which I'll speak about briefly. So here is a molluscum, right? It's beautiful. We've got these purple Henderson-Patterson bodies. Nothing else really looks like that. I'm just including it for completeness sake. Here, we covered this a little earlier in the interface section, but we see ballooning degeneration of the epidermis, right? Looking at the DEJ, you should note that you have lymphocytes lining up vacuolar alteration and necrosis of some of the epidermal cells. And then this is a type of death where the epidermis is literally pulling away from itself with these strands left behind. And this pulling away kind of death is called ballooning or reticular degeneration. This is a pattern we see in hand, foot, and mouth. This is a pattern we would see in ORF. This is a pattern we might see in Hydroa vacciniforme. So a few different viral things have this pattern. Okay, again, another look at the interface and the ballooning degeneration. This was a case of hand, foot, and mouth. Now this, on first blush, looks a little bit like ballooning degeneration. You have your interface again, now your keratinocytes are dying, but this time your keratinocytes are dying with a special look to them, a special viral cytopathic change, where if you notice here, you have this little outline around your nuclei. Normally nuclei are even colored throughout. That means the chromatin is evenly distributed, right? Remember, chromatin is that DNA material. When we talk about marginating chromatin, we mean that DNA material marginates to the outer rim of the cell, of the nucleus. And now it looks like a little outline, dark outline with a clear center rather than evenly colored throughout. So that's what we talk about with margination. And here you see these dying keratinocytes are molding together and look multinucleated. So that is the special kind of death that we see with herpes virus infections. Okay, so herpes simplex virus, VZV also. When we say multinucleated cells, we're not talking about the histiocytes that are multinucleated. We're talking about these keratinocytes where the chromatin is marginated and they're dying in this clustered death. Okay, here's another close look at multinucleated keratinocytes that are dying with marginated chromatin. Okay, and this is what I call a dirty vesicle, right? If you look at the contents of a herpes virus blister, it's not really a vesicle, it's not really a pustule. That's because there's a few neutrophils, there's a little serum and other inflammatory cells, but there's also a bunch of dead cells. So it's murky in there, dirty vesicle. Okay, another one. Now look, you've got this interface. This one, you could see these elongated twistiocytes a little bit better. And then you have this blister with multinucleation of the dying keratinocytes. And sometimes when the infection's really old, you lose the nuclei and you can't see that they were marginated, but sometimes you get little clues that you had a little bit of marginated chromatin as the keratinocytes clumped up and died. Look at these nice little twistiocytes. Okay, here, on this case, when I had it, at first I was like, oh, this is easy. This is going to be allergic contact dermatitis. Look at all these intraepidermal vesicles. What else looks like that? But when I went in closely, I noticed, wait a minute, look at these lymphocytes. These lymphocytes are lining up at the DEJ almost like they're wanting to cause an interface. And then look at these elongated twistiocytes. We've got this interface with elongated twistiocytes and intraepidermal vesiculation. So this made me think of an infection. So what kind of infection might give you vesicles like this? Well, this was a 16-year-old who had mono. And actually, this was an interesting manifestation of Giannotti-Crosti for her. So you can get vesicular lesions. And in that case, it will be these kind of spongiotic vesicles with an interface. Okay, on to warts. Most important thing I want you to know about warts is the architecture. Okay, they're digitated or papillated, whatever you want to call it, on top, meaning they're pointy. And they curve inward on the bottom. Everyone can appreciate how these reedy curve inward. This hand holding, we call it. This is the shape of a wart. There are different things that can be digitated or papillated on top, but the reedy may not connect in a curved manner. Prurigo nodularis is one of the ones that you're going to want to distinguish from a wart. Sometimes even sebs can look like warts, but if it doesn't curve inward, it's probably not a wart. Yes, we talk about coilocytes. Coilocytes are great for a fresh wart, but as we know, our expectation is that eventually your immune system will clear the virus. When you clear the virus, you may regress the entire wart, or you may just be left with the architecture of the wart. The framing of the house is left behind, though all the furniture is gone. Okay. so look in here. This is a coilocyte, right? You have little viral particles, you have kind of clumpy keratohyalin granules, and you have these white spaces. This is coilocytic change. You see this in kids because their warts tend to be fresh. You might see it in an immunocompromised or an older patient. But usually like a regular adult, you don't see a lot of really, really fresh warts because their immune systems started to recognize it. Here's another wart, digitated, little hand-holdy, nice coilocytes, active wart. This is an old wart, okay? We don't see as much of the epidermal hyperplasia. It's kind of shriveled down. We don't see any coilocytic change. It's starting to have a lot of overlap with a lot of sebs, and a lot of old sebs or verrucous keratoses, I think, are regressed warts. A subset of them are, a subset aren't. Of course, sebs can look like a lot of different things. So this is what a wart where you've probably cleared the virus looks like. This is another warty shape, right? Digitated on top, hand-holdy and curved on bottom, but this one looks a little bit different. You have these epithelial cells down here that are really pale looking, pale, and they kind of line up a little bit like piano keys on the bottom. This should remind people of the tricholemal portion of a hair follicle, right? So if you have a warty shape with tricholemal differentiation, that is what has been referred to as tricholemoma. I'll admit that not everyone believes that tricholemomas are warts, but generally kind of in the Ackerman lineage of training, we believe that they're warts. They're certainly shaped like warts, and they just have this different differentiation of the epithelium. Okay. This is epidermodysplasia verruciformis. So we know that these have different HPV types, and this is what the virus looks like in the epithelium. Instead of that coilocyte we saw with the verruca vulgaris, we now see this kind of blue-gray cytoplasm in our cells with the active inflammation. So EDV. Unfortunately, this was a 16-year-old, right? We can get this acquired or we can have it as a hereditary syndrome. And this 16-year-old had it as a hereditary syndrome, and long-term with HPV virus, you can turn into cancer. And so she was getting squam in situ, which we'll start covering in the next section. She was getting squam in situ in all of her little EDV lesions. This is a different shape of warts. We saw pointy on top, hand-holding on bottom. There's this other shape, this kind of round bulbous shape. Still curves inward on the bottom, but this round bulbous shape is a shape that should remind you of a condyloma type of wart, right? And this condyloma has a little bit of active coilocytic change, so I would expect an HPV study to be positive. But remember, once you clear the virus and you're left with this shape, certainly sebs and intertriginous areas can look similar, or even taggy things. So sometimes it's hard for your pathologist to tell you if you're looking at a warty looking seb or an old condyloma, and your HPV study won't necessarily be positive if you've cleared the virus. But this one I would expect to be positive. And here is your HPV study. It's an in situ hybridization, and this is the positivity in the nuclei where you see those coilocytes. Other viral things, of course, we see viral exanthems, and these can be pretty nonspecific, either just a superficial perivascular dermatitis, plus or minus an interface. I love seeing twistiocytes because that helps me favor it slightly over, say, a drug eruption, but you can't hang your hat on anything. You may or may not have a few eosinophils, right? So this was, see, there's this little interface, superficial perivascular dermatitis, kind of nonspecific. We didn't see any EOs. We saw some elongated, more twistiocyte-like cells, so favored viral exanthem, but of course a lot of that needs to be worked out clinically. You see many elongated cells, nonspecific superficial perivascular lymphocytic infiltrate. It could be purpuric, right? You can have purpuric drug eruptions, purpuric viral exanthems. This is actually another case of an interface. We got a lot of PIPA, we got a lot of necrotic cells. This is a case of erythema multiforme, which again, remember, is technically usually a viral process. So again, it fits the interface superficial perivascular pattern. Recently, there's been talk of these COVID toes, which remember, there's different types of changes you can see in the feet. You can either see this Pernio-like picture where it both clinically and histopathically histopathologically looks like pernio, or you might see something that looks more like the result of a thromboembolic process. So just as a reminder, pernio looks like a lymphocytic infiltrate. It's in our lymphocytic infiltrate differential with PMLE and tumid lupus and gyrate erythemas, etc. And these have been noted to be seronegative, so people who are not very infectious. And I wonder if this is one of our first links to these autoimmune conditions that we can't explain and viral infections that we never knew we had. Who knows? But this is a case of pernio, acral skin lymphocytic infiltrate, right? Superficial and deep, lymphocytic, not significant interface. You might have a lot of edema, and nothing else more than that. This is not COVID, but you know, it would look pretty much identical. Perivascular, lymphocytic. Okay. Moving on to protozoal infections. So mostly we think about leishmaniasis. That's what we would see clinically more commonly. You're going to see a dense dermal infiltrate of lymphs and histiocytes and plasma cells and these parasitized organisms that can look a lot like histo. These organisms have no capsule, which is supposed to help you distinguish from histo, which might have more of a little halo, but it's hard because they're really small. Maybe you can tell the marquee sign where these line up along the edge of the histiocyte, but again, if they're crowded in a histiocyte, it can be really tough. One of the things I find helpful is that recently we discovered that CD1A, an immunostain that highlights Langerhans cells, right? It highlights these organisms in the majority of cases, especially in New World leishmaniasis. So every case I've had recently is stain positive with this, which is helpful. And then certainly you can do fungal stains for histo. It's just an additional piece of information. But here, dense dermal infiltrate with histiocytes and neutrophils, and you can see packed inside your histiocytes, there's all these little organisms, right? I can't really appreciate a marquee sign in this, so I usually do a stain. I don't like to be wrong and tell people the wrong organism, but see how they're much smaller than even blasto, which is on the small end of the spectrum. This is another case. These ones have less of a halo than that one, but you can see these tiny, tiny little organisms packed in these purple histiocytes, right? And this is a CD1A immunostain showing the organisms highlighted. Okay, infestations. So we see scabies, we see tick bites, we see myiasis a little less often. They generally give you allergic responses, so that's how we're going to see it. Here, scabies is an organism that, you know, burrows very superficially, so we'll see it up in the cornified layer. You might see the scabies mite, you might see its poop, you might see its ovum or its egg, but it will be up in the cornified layer, and then you'll have kind of an allergic response below, which is going to be lymphocytes and eosinophils, right? This particular person had a lot of little scabies, so not nodular scabies, sorry, like crusted scabies, not Norwegian scabies. Now, when you have parts deeper down like this is a bite from a tick, okay? These bites go deeper, and then you have this dense lymphocytic infiltrate with eosinophils surrounding, because that's your allergic response. If you see the yellow parts, you know, I can't tell you what kind of tick this is, but yellow parts would be mouth parts, and we'd have to see the tick grossly to kind of be able to identify it. This is the shape of a worm for myiasis. And this is the allergic infiltrate surrounding that. You can see the little guts, and it wouldn't have the yellow mouth parts that a tick would have. Closer look. This is a closer look at some mouth parts of a tick, yellow bits. This one happens to be superficial. We didn't catch it inside the tissue. Looking beneath a tick bite, one thing that you'll often see is fibrin in a vessel. So it looks like you get a vasculitis. But a vasculitis right under an ulcer, you always have to be suspicious. Is it a primary vasculitis or is it secondary? And then certainly with tick bites, you can see the vasculitis. See that? Okay, so what are the take-home points for this large somewhat all-encompassing chapter. Well, if you see separative and granulomatous inflammation and there's no ruptured cyst, then think about infection until you prove it otherwise. If you see a superficial infection and you see organisms, yeasts are easy to see. Dermatophyte is hard to see, so you have to be suspicious and do a stain. If you see an interface dermatitis and you appreciate twistiocytes, think about infections, okay? If you see a lymphocytic infiltrate and you've decided that you're not looking at PMLE or lupus or anything like that, think about gyrate erythemas, which can include an infection such as Lyme. Think about COVID nowadays. Think about rickettsial things, especially if you see a vasculitis. And certainly necrotic papules, think about infection as well. And that's it. And that ends our part 1, inflammatory. And our next section will begin with neoplasms.